So if you see here, this is a maxilla we planned for rehabilitation. See the nasomaxillary nasopalatal canal. See the nasal spine. There is a long distance between the nasal spine or the anterior nasal wall. That means anterior to the canal there is a good bone is there. Okay, the width is good here. You will see. So this is the pano. So what is our? If you see here, it is more white here. 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 So all the buttresses they are more white here, more cortical. So we are placing one implant in right pterygoid. We are placing another implant in left pterygoid. We are placing one implant in nasomaxillary buttress on right pterygoid, right nasomaxillary, left maxillomaxillary, and one in the anterior and one on the thing. So 6 anatomical buttresses and connecting all the implants with the titanium bar, screw retained titanium bar. So we cannot place single piece implants and do welding and do processes. That won't work, right? Because of force distribution may not be favorable. The inter-implant distance will be much more and the number of implants will be less. The welding cannot withstand the system. So for better force distribution we need a screw retained multi-unit single piece implant and screw retained titanium bar and placement of implant in the buttresses where normally force distribution happens during chewing. Okay, so these are the buttress are nothing but the pathway through which the forces get dissipated towards the skull. So the key implants are the pterygoid. If you cannot place pterygoid, then you have to think about zygoma. Okay, so in abroad they will start, before starting the procedure they will inform to the patient. If pterygoid is not possible, then we may have to do zygoma. They will tell like that, because with conventional the possibility of not engaging the pterygoid is quite more. Okay, because but with the basal single piece you can get more success with this design. Okay, so the pterygoid area looks very much different in different section. There is severe pneumatization here, and of course the X-ray is not fully covering the pterygoid, right? Yeah, this section will explain the difficulties in pterygoid. This is the crestal bone. So the crestal bone is only 1 mm or 2 mm. You can poke a probe and it will go into the sinus, and the sinus is healthy. See the sinus lining, it is around 1 mm thick, which is a sign that it is healthy. For smokers, the sinus membrane will be very much thick. For sinusitis patient, the sinus will be filled with tissue. But here it is sinus is healthy. The sinus membrane is thickness is good. Okay. So patient mostly a non-smoker. Chronic smoker. Okay. That means there is one condition called the sinus membrane will it will atrophy. Okay. So this is a little bit of tuberosity bone which is left after the invasion by the sinus, after the attack by sinus. Okay, this is a
fusion. No.
Oh, this is a pterygoid maybe. See, this you have to tilt and see. This is a pterygoid ambulance where we palpate. Okay, so from the posterior wall of the sinus till here only this bone is there. So our drill exactly should go in this direction. If it goes here, it will miss the pterygoid. It will go in this direction, it will miss the pterygoid and may go into the sinus. So during drilling, so where you are going to start? If you start from here, you cannot achieve this target area. Okay, So the starting point should be more distant. The more the sinus is expanding distally, the more the starting point is moving distally. So more sinus expansion, the first modification you have to do is start your starting point of the drilling will be more distal. Usually we tell from 7 area you start the drilling. When doctors ask pterygoid what is the starting point, you start from 7 area. But here if you start from 7, no, you cannot achieve a proper pterygoid. You are starting from the 8, very close to the distal border of tuberosity, and drill 6 mm or 7 mm, take a IUPA, whether the drill is. So during planning, what you do is make the implant like a drill. Okay, make the implant like a drill, 2.8 mm. So the drill is here, like this, in IUPA, you tilt slightly distally. If your drill is going like this, redirect it in this direction. So our aim is between here and here. That is the narrow target area. If your drill goes into this posterior wall of the sinus and this pterygoid notch, then you are into the pterygoid without any doubt. So even in severe sinus pneumatization cases, you can do pterygoid by planning in a software, planning software, not even in CBCT. Only in planning software you can find this bone. But if you see this X-ray in a panoramic view, it will look like there is no. You cannot see this bone in a panoramic view. You cannot see this this bone. It will look like this is fully invaded by sinus. But most of the time, the sinus cannot invade the full this area. Some amount will be there, which we can see in the software. Which software? Planning software. So what the CBCT CD comes, it is a viewing software. Viewing software, the information is very less. Only in the planning software you will get more details. So the software matters more than the CBCT.
The drill itself is 2.8, which is almost covering half of the bone.
Yeah, that is no problem, because only crustally it will be 4.2 mm the implant, but it is, as it goes apically, it is tapering. Even if it is a little bit goes into the sinus expansion, it's no problem.
If we drill mistakenly away from the bone, if we drill it in the wrong position, can we re-drill it?
Yes, that is what. If you go too much depth, then you take IOPA, you cannot redirect. So drill only 8 mm or 10 mm. When you feel the resistance, when you are feeling resistance, that means either you are in this wall, or either you are in the target area, or either you are in this area. So the moment you get the resistance, stop the drilling and take IOP. Okay. So if you are here, that means the resistance is from this part of the bone, which is a mistake. You are directing too distally. So direct it here. If your drill is like this, you will be feeling resistance because it is a sinus wall. That means it is a mistake. Redirect it here. Okay. That's it. So the key implant is the pterygoids. We have to, because the moment you are watching the pterygoid, then you need zygomas, or you have to give long cantilever from first premolar. Okay, today's morning patient, the implant head was emerging from second premolar. I intentionally did that because from 4 also I could able to start the drilling, but from starting from 5 it's quite challenging. Even though it is challenging, we started the drilling from 2-5 area morning surgery, because if the pterygoid, because the pterygoid we placed is a very soft bone. If somehow the pterygoid it doesn't work it out, we can give cantilever from the 2-5, right? But your implant is starting from 2-3. then pterygoid is must. If we destroy the pterygoid, if we cannot able to place pterygoid, then you don't have any other option than to do pterygoid, right? Zygoma. For one patient, even we did give cantilever from 2-3. Only one patient, because we placed pterygoid. I am not happy with the pterygoid. The pterygoid was like this. I was not very happy. I wanted to redirect somewhere here, but it was already, the bone was smashed. I couldn't be able to place any pterygoid. Then we gave cantilever from 2-3. It has been now 10 months. The patient is doing fine. Though he has not come for checkup through phone, we are regularly following him. He is doing fine. Okay. But for that patient, we did right pterygoid. So it may take up the load.
But all-on-4 concept is also very similar to that.
All-on-4 concept is also is very similar, but they won't stop the drill, stop the last implant in canning. They will stop the last implant from first premolar. They will give cantilever, but in the provisional processes, they will give. They won't give any cantilever. Only from first premolar to first premolar, some small miniature process will be there. After osseointegration, they will give teeth, but the number of teeth will be very less, 10 teeth. If the implant is starting from premolar, ending in premolar, then one premolar, maybe one molar will come. Okay. So right pterygoid will see. Here it looks good. It is not a very easy situation, but it is good. Okay. This is excellent bone. We'll start the. We'll see the buccolingual view. Okay. A good amount of bone is the right pterygoid. You can place 16 mm, 18 mm implant. It is quite easy. But the thing is, the right side sinus is
Infected.
chronic infected. So this is the end of the tuberosity. This is the pterygoid notch. So here also you have to start the drilling from 8, not from 7. If you start from 7, you will enter the sinus. The sinus has been invaded. But here this zone is quite more from the posterior wall of the sinus and this pterygoid angular notch. This zone is quite, so you can place even a 20 mm implant comfortably. But here if you see in this angle, in one particular angulation, it is entering the, what is this radiolucency?
Nasopalate.
Nasopalate.
Great.
GPC.
Greater palatine canal. So when you feel the resistance, sometimes it may be the greater palatine canal. The moment we drop the resistance, lot of bleeding will come. Right? Have you seen? Lot of bleeding suddenly will come from the drill reset. That is because we have entered the greater palatine canal. But it won't do any problem. The moment you place implant, it will arrest, or even if you don't place any implant, just compression, it will arrest.
What about the nerves?
Nothing will happen. It's just a pricking injury, nothing will happen. See, the numbness of the palate, the patient cannot able to feel it very much.
Because of the scar tissue.
Yes, scar tissue. If the lip is numb, the patient will immediately will come to know.
How far is sufficient in placing pterygoid implants? You said you can place even around 20 mm also.
How much bone is there you can place, that's it.
What is the minimum?
No, not like that. If you get good stability, even 10 mm is available. Sometimes we have placed only 10 mm, only 10 mm bone only available. Okay, so the amount of available pterygoid is not a fixed one. It will vary from patient to patient.
So if there is 20 mm of bone,
yeah, you can place
20 mm.
Better to place. Why to waste that bone? Safely, if you can place, but I will stick with 18. If 20 mm is there, I will place only 18. More than that, not needed. Whether you place 16 or 18, what is the difference? Whether you achieve 40 Newton or 80 Newton, there is no difference. People tell I achieved 80 Newton in pterygoid. There is no use for in that.
Mm-hmm.
What is the use in it? Minimum is 40. Today's morning patient we achieved only 25. On left side 25 or 30. Okay, but that is enough. The moment you connect all the implant with a good titanium bar, only when you do welding or use cobalt chromium or nickel some kind of bar or hybrid bridge, no, this kind of stability is needed. People worry more about very stability under a decent stability more than 30 also in 30 mm stability, 30 Newton stability, all the 6 implants they work fine. So on the initial phase of the career, doctors they worry too much about the stability. They will tell, I achieved 100, I achieved 120, I achieved 1000 and all. But it is not enough. See, it is not needed. They are not very.
And stability is important or support is enough?
What is stability? What is
Stability means if we are engaging the bone directly and we get strength.
Okay, torque.
Torque. And that is stability. Support means like they are using techniques where they engage the tooth, the left out tooth, they will engage the implant in it like this.
Okay.
It is a support only, no sir.
It is also will come under stability.
Sir. What I'm asking is, you must support irundhalum, it's more than
enough. Yes, it's more than enough. But is it a predictable one? We don't know. Okay. Okay, coming to the, we'll finish the anterior one. They are quite easy. Nasomaxillary, it is axis for brain. See, if you want to place implants all straight anteriorly, 6 implants, that is it. There is no need to have any thinking and all. But if you want to place nasomaxillary and all, definitely some planning is needed. Without planning, here it is a kind of a tubular shape. Okay, what are the 4 shapes of upper anterior region in CBCT cross section? Tell the name. What is the 4? Hourglass.
Funnel.
Parallel.
No, I am not talking about nasopalatal canal. I am talking about the
Convex.
alveolus. Find out and tell tomorrow. No, concavity is nothing but labial anatomy. I am talking about the cross sectional shape. See, this is like 2 parallel walls. Can you see?
Yes.
Sometimes the palate will be going like this. Okay. No issues. Till tomorrow. There is some good article in
that in the PPT, sir.
Okay. Find the article. So usually we start the drilling not from central incisor. We start the drilling from 1, 2 and 1, 1, right?
2.
Or even in lateral incisor also. Okay. So either you can place implant following the palatal wall, you will achieve more length, 17-19 mm, or you can do palatal approach, drill parallel to the labial bone. Here also you are getting good bone. Okay. So either way, you can get good stability. The bone quality is good. There is no doubt about it. So it is a quite straightforward situation in the anterior. There is no challenge here. Okay. So this is lateral incisor area, right? You can place a decent stable implant. Between 2.1 and 2.2 also you can place. So 2 implants in the anterior buttress next to midline. The technique is very simple. Just expose the nasopalatal canal, drill lateral to the nasopalatal canal. That's it. Okay. Now we will plan the nasomaxillary buttress. So first you have to plan the starting point, whether from canine, first premolar, second premolar. From canine, do you want to start? No need. There is a good bone in the first premolar. Can you able to start from second premolar? You can start, but you have to do tilting more. So first we will start the planning from second premolar, and 25 degree I am tilting, you are in good bone. Okay, the 16 mm is there. That is more than enough. Palatally, if you tilt buccally, this is sinus, right? This is, if you tilt buccally, you will be in the sinus. Okay, so we will do another planning, and not only that, it is in sinus, right? Yeah. So you have to tilt more from second premolar, right? See here, from second premolar, if you are starting, you have to tilt more to avoid sinus. You can do the drilling parallel to the labial plate or parallel to the buccal plate. Anything is fine. If you are doing drilling parallel to the palatal plate, you will be engaging the nasal floor. If you are drilling parallel to the buccal plate, you will be engaging the buttress area and nasal floor also a little bit. So what we can do is, we'll move the shifting point from 4. Okay. From 4 we can do the drilling. Either parallel to the buccal plate, engaging the nasomaxillary buttress, or parallel to the palatal aspect. But if you drill parallel to the palatal aspect, what is the drawback?
The implant size reduces.
Implant height reduces, but that is not a problem. But the bone quality is good. Even 10 mm implant we are placing.
Bend.
Yes, the abutment will be buccally inclined. You have to bend it. But if you drill from here, then the abutment is in the correct position, perfect position. So what is this radiolucency here?
Sinus.
It is not sinus. It is not sinus. See here, the sinus stops here. It is not bone marrow. It is canaliculus sinosis. Okay. It is a branch of okay. Okay, so the right side nasomaxillary buttress is over. Inferior blood. Inferior means it is in the lower jaw.
Sorry, sir. The inferior.
So
Intraorbital.
no, check. Yes, you are close. See here, in the 3D view, you can check where is the apex is residing. So during flap elevation, I will mark the target area here with pencil, right? And another thing is, above the canine is the target area. Okay, we can tilt it little bit mesial also, right? But there is no need, because you are leaving this bone, so no need to tilt very much mesially. You can.
But we can surpass the canaliculus.
Yes. Okay. Even if you go into the canalicular sinosis, it is not a big deal. Okay. So you have to finalize 3 things for placing a good nasomaxillary buttress implant. One is the starting point from mesiodistal. Next one is the target area. Target area is just lateral to the lateral rim. I will be marking with pencil. And crustally, where you are going to start. From palatally, we can start. Okay.
You see this space, sir. This is space to palatal.
No issues. No issues. That won't make any difference. See here. You can start from here. Okay, from the middle crest, or you can start from the palatal crest also. No problem. That won't make any difference. Yeah. See, in this section, can you see a small radiolucency canal here? It comes like this. Okay, that is the canaliculus sinus. Canalis sinus, something.
Now it was.
Cancel. Okay. So we will finalize the left nasomaxillary buttress implant. And the challenge is there is a crestal bone loss in 5. So from 5 starting is a may not be a good idea, right? Why to take some risk? But if we are not getting pterygoid, then we may have to start from the 4. Sorry, 5. Okay, so we'll start from 4. Okay, we will tilt. Even 4 is not good crystally, right? So here you can see. See the bone loss here in the 5. These are the problems. If the patient has come 8-10 months back, this area would be filled with bone. We could have started from here. So what we can do is we will try from the 4. Yeah, 4 is very much ideal, right? From 4 we can tilt laterally, labially. You can place a good implant. So anatomically, target area where it comes in the corner. So left side, I will be marking the target area in this corner of the nasal rim. But here, just away from the nasal rim, right side. The rim is here, but the target area is here. We will try the target area a little bit away from the rim. That is much better, right? Yeah, that is much better. You will get more bone. This is the buttress. Okay, this is the buttress. Suddenly you are getting more bone.